It's like $2,000 for this medication, and it'll help with the cyanide poisoning. But we don't recommend this. We would always consult with our toxicologist and the surgeons and look at the patient. Because what happens, this hydroxycobalamin, this medication that we give, it turns their urine into fuchsia color. So any colorimetric lab that we draw is going to be falsely elevated because of that. So AST, bilirubin, creatinine, glucose, MAD, creatinine kinase, phosphorus, all those labs are going to be altered because of that medication. And it discolors the urine for weeks, and even the fluid coming out of their tissues when we take them to the operating room, it's kind of pinkish tinge. And if the patient's on dialysis, it can also cause a positive blood leak and shut the dialysis machine off. So the initial treatment with any inhalation cyanide CO poisoning is getting them out of the environment and oxygen. This is just showing somebody's lower airway, and that's when they can select the lining of their trachea if they have burns in their lower airway. This is a pediatric patient. Mom was asleep on the couch. Dad went into the shower, took the child with him because the mom was asleep, so we didn't want to leave the child alone. But the child ended up getting burns and was transported to us. When the fire department arrived, they got an IV in the child's foot, the sap in his vein, and all they had was normal saline. It's still a crystalloid, so they started that and they gave a pediatric bolus, 20 cc's per kilogram. So the child weighed 5 kilograms and ended up to 100 cc bolus of fluid en route. And they carried the child in. And we should be concerned about his airway. Yeah, and you know, you can always take the tube out, you may not be able to get it in. So here we are getting ready to intubate. Always have at least a half a size below and a half a size tube above the size that it requires. And use your cheat sheets or your Broslow system or your pediatric system that tells you what size ET tube, IV, and things like that. He was intubated. And you get another IV in them. And those wounds, are they super partial or full thickness? Partial. Yeah, partial or pink and they're moist. So we put a silver impregnated dressing on him. And on day 2, we were able to pull out the ET tube. The swelling had gone down. And on day 5, he was discharged home and followed up in our clinic. And that felt dressing stayed on until the wounds underneath was healed. And it releases silver. Silvadene, that cream, after about 8 to 12 hours, it stops working, the antimicrobial effects of it. But these silver impregnated dressings release silver for days. So we can leave them on for 3, 5, or 7 days, depending on what silver impregnated dressing it is. And it's less painful for the kiddo.
What's the likelihood if they're allergic to this?
Pardon me?
How many percentage of the patients are allergic to that silver?
Oh, how many patients are allergic to silver? Only a few, and if they are, then we'll stop using the Silvadene because it dumps the silver, and we'll use the silver impregnated ones because they slowly release silver.
Okay.
Good question. I'm going to recruit you. Okay, so we've talked about inhalation injuries. Now we'll talk about electrical injuries. And with electrical injuries, we kind of say that they're the grand masquerader. What you see on the outside is just the tip of the iceberg, because a lot of injury is deep internal. As they come in contact with a high voltage, that energy travels, it creates heat in the deep tissues. So you may not even see external signs of damage unless they can start swelling, and they can deep internal injury. And alternating currents, it can actually be worse because it can freeze the victim to the source and they can't let go. Where direct current, they can be thrown. So then they can have traumatic injuries from that. And just know that with any electrical injury, whether they stick their finger in the socket or a fork in the wall socket, that they can have any EKG arrhythmias. So the patient should be on a monitor. And then we're also going to draw serial CPKs to see if there's any damage to it. And then, as I mentioned, the rhabdo from the damaged muscle. And that can, cause the kidneys to stop working if it clogs the kidneys. So we're gonna increase their fluids. In the burn center, also, if we increase the fluids, and the urine isn't clearing, we can also give them bicarb to alkalize the urine to break down that myoglobin, and then mannitol to diurese them. Because now we're giving them almost double the amount of fluid. The Parkland formula is usually 4 cc's, but with an electrical injury, we can go up to 7 cc's, almost double the amount. Because if you think about it, you're calculating their fluid by their TBSA, and it could be very small external part, so it could be more deep internal injury. And that's a bad sign when you see urine like that. This gentleman was carrying a metal pole, there were some wires hanging down, he came in contact with it, the fireman brought him in, and we thought this was his only area. You can see it's blistered, there's the nurse cleaning it, and there's what we have, so that's deep, full thickness. We were gonna admit him, he was gonna have to go to surgery to have that debrided, and he had a full head of hair, but when I was looking down at him and talking to him, I noticed that his hair was singed. So we shaved his head, and by below, that's where he came in contact with it, was his head. And then it went through his body and out his foot. So with electrical injuries, as we were just talking up here, you wanna look for multiple sites. The advanced burn life support says don't call them entrance and exit wounds, call them contact sites. Because we may not be able to identify what is the entrance and what is the exit. But pretty much he came in contact there and it was out his foot. This gentleman, it's kind of obvious here, he had work gloves on, he was up in a cherry picker, and he came in contact with a high tension line. He had work gloves on, but the electricity got through the glove, and the skin is the most resistant, so it takes a while to get through the skin, believe it or not, the epidermis. And so it's usually charred right there until it enters. And then he also, his clothes caught on fire, so he has thermal burns and electrical burns. I took his work glove off and opened up his hand, and you can see little contact sites out of each finger where it blew out. That arm's dead. We're using betadine, and he's gonna get an amputation. His initial heart rhythm was in an SVT of 180. So whenever somebody comes in contact with electricity, monitor for arrhythmias. There's one of the first trips to the operating room, he was thrombosed blood vessels. He had to have multiple trips to the operating room. You can see deep dead muscle. Again, he threw his right hand down, out his thighs, back of his knees, back in and out of his foot. And there he is on his foot. We put a skin graft on it, but it was over tendon and bone, so the blood flow didn't go up into it, so we had to take a quad muscle and put over the top of the foot, and so the graft would have a good blood supply. And he was able to go back to work. He worked for one of the major utility companies. Here he is in our outpatient clinic, but now he works in safety. I know, kind of funny, but, and the goal is not just for a patient to survive the burn unit, but to go back to work or to go back to their functioning life. Lightning injuries, usually they're not very deep injuries. They travel over the outside of the body about 0.03 seconds, so we don't have the deep internal injuries from lightning strikes.
I'm so sorry to go back to that picture.
Yeah.
He had a
Yes, tracheostomy.
tracheostomy done.
Yeah.
So they couldn't get him intubated, so they did that.
No, he was intubated initially, but when we have them intubated for a long period of time, he had multiple surgeries, so they ended up just doing tracheostomy, and then you have to wean him off of it.
Okay.
Yeah. And then he had a stoma once they took it out. So he did good. Okay, lightning strikes, again, they're not gonna have the deep internal injuries. They can have like a burning pattern where the lightning came over the top of their skin, or a little capillary rupturing. But one of the most common injuries from lightning strike, if you think of it as like a blast injury, they can have ruptured tympanic membranes. eardrums for just about 2 weeks, and they usually heal on their own. But that's one thing you want to assess for. Like I was yelling at this, not yelling at this patient, but talking to him loud. His wife said, "Why are you yelling at him?" I said, "Well, does he have a hearing aid?" And she said, "No." And then we looked inside his ears and we noticed he had ruptured tympanic membranes. If they get a lightning strike or electrical strike above the clavicles, they're at risk for cataracts. The whites of your eyes are like protein, like egg whites, exposed to heat, it can denature the protein. So they're all gonna get ophthalmology consults from the time they're admitted and followed. They can have cataracts up to 3 years later. Okay, these guys were Phoenix landscapers, and they were landscaping, and they were pulling up and packing up, and a storm came through. They were standing in a puddle, and they got struck by lightning, and both of them were thrown. When Mr. Mendoza, one went to another trauma center, and then one came directly to us. The one that went to the other trauma center, he had no movement from the waist down. So he had lightning paralysis, which I'm not sure if it says in your textbook, and I read about it, but I'd never seen it in 30 years until these guys came in. So I asked, no, we didn't give any steroids for that, for spinal cord injury, no steroids. And my trauma burn director said it was probably the lightning strike, the increased energy caused a shock to the spinal cord. And then that shock wore off eventually without any intervention. He was able to move like 12 hours later. Here's another patient out of a textbook. You can see that lightning pattern. This gentleman, he was riding a horse out of the West Valley, struck by lightning, the horse died. There was somebody that did CPR, a bystander, ALS came, they gave him, he was in VFib, pulseless, they shocked him, they gave him lots of epinephrine, cardiac ACLS drugs, and transported him to us. And here, so again, he was hit in the chest area, he had burns on his forearm and his leg. There's deep, you can see deep burns there, deep burns here on his arm. And there's a skin graft. So he ended up with a 17% total body surface area burns. He had a traumatic brain injury, and they think it was probably not only from the lightning, but also all the multi-dose of the epinephrine that he got. Caused the hypertensive bleed on him. But he ended up doing well. He ended up being discharged to a neuro rehab, and here he is at one of our burn symposiums that we have. So survived. Again, cardiac arrest in the field, good CPR, and transported quickly. Any questions about electrical lightning? We're going to finish good. This chemical injuries, what's worse, acid or alkali? Alkali, good.